Bismillahirrahmanirrahim. In this video, we are discussing the connection between rheumatoid arthritis and anemia. This is one of the most favorite station entertained by the examiners of CPSP in IMM as well as in Part 2. Rheumatoid arthritis and anemia may seem like two unrelated conditions, but two often go hand in hand. It is believed that up to 70% of the RA patients develop anemia. Anemia could be due to a variety of the reasons in the RA. The couple of the reasons are there in the RA for the causes of anemia. Causes of anemia will have to be determined in order to treat it because the management is dependent upon the cause. There are the various causes of anemia in rheumatoid arthritis, such as anemia of chronic disease, iron deficiency anemia, which could be due to gastrointestinal loss due to NSAIDs, as NSAIDs are also used in RA. Folate deficiency, which can be secondary to the methotrexate. Methotrexate is one of the anchor agent, the DMARD, that is used in the RA. Pernicious anemia is rheumatoid arthritis itself is the inflammatory condition and autoimmune condition. Therefore, the pernicious anemia could be associated with it because it is a rule if one autoimmune disease is there and other autoimmune disease could also be there. Therefore, you have to rule out that. Bone marrow suppression. In the previous time, gold was also used in the treatment of the RA, but nowadays it is not used. But other drugs such as methotrexate, sulfasalazine, these can be used in the rheumatoid arthritis and they have got direct bone marrow suppressing impact. Felty syndrome, which is actually the combination of rheumatoid arthritis, splenomegaly and leukopenia. When you will suspect Felty syndrome in the patients of RA, whenever the patient is presenting to you with fever because of leukopenia and on examination you are having splenomegaly and ulcers on the leg, suspect of the Felty syndrome. Autoimmune hemolytic anemia is discussed earlier that the autoimmune conditions can be interlinked with each other. And anemia of the renal disease, there are various reasons of the renal involvement in the rheumatoid arthritis, such as NSAIDs which are used in the RA, they can lead to the NSAID induced nephritis, amyloidosis, because RA is the chronic inflammatory condition and any chronic inflammation may lead to the amyloidosis, and the vasculitis and also other reasons. So anemia of the renal disease, whenever the renal involvement is there in the rheumatoid arthritis, it may also cause anemia. Pseudo-Felty syndrome. This is also known as the large granular lymphocyte syndrome. The patient typically presents just like that of the Felty syndrome. It is a theoretical diagnosis. On the CBC, you would have the large granular lymphocyte, that is the LGL. So usually it appears in the station to determine the cause, whether it is anemia of chronic disease, or it is the iron deficiency anemia, or it is B12 deficiency, or it is folate deficiency, or it is autoimmune hemolytic anemia or pernicious anemia. So anemia of chronic disease, I am not going in detail of it, that how hepcidin is released and how it causes the sequestration of iron into mitochondria and macrophages. Just on the lab, how you will determine the anemia of chronic disease. Peripheral film, on the peripheral film, usually there is a normochromic normocytic anemia which is against the iron deficiency anemia, because in the iron deficiency anemia there is the hypochromic microcytic anemia, but rarely there could also be microcytic and hypochromic features. Low serum iron, it is same to that of the iron deficiency anemia. In the iron deficiency anemia there is also the low serum iron. Normal to low TIBC, total iron binding capacity. This is against the iron deficiency anemia. The TIBC is increased in the iron deficiency anemia, and increased serum ferritin. It is decreased in the iron deficiency anemia. Now, it is very easy to remember the ferritin level is increased in anemia of chronic disease because ferritin is the acute phase reactant, and in any inflammation the acute phase reactants are increased. So it is very easy to remember that ferritin is increased in the anemia of chronic disease because anemia of chronic disease is the feature of the chronic inflammatory conditions. Iron deficiency anemia, as I told that on the peripheral film there would be the microcytic hypochromic picture, decreased serum ferritin, increased TIBC, decreased transferrin saturation, and decreased iron. Now coming towards the B12 deficiency, usually on the peripheral film there will be the picture of megaloblastic anemia and hypersegmented neutrophils, low serum B12. But if the patient is having the borderline B12 level, then go for the serum methylmalonic acid homocysteine level, and these both are very useful because they both are elevated, unlike that of the folate deficiency in which the methylmalonic acid level is normal, it is not raised. Now again it is very easy to remember that which component is elevated, that is homocysteine level. It is elevated in both B12 level and the folate level. Homo means same, that means cysteine is same thing which is elevated in folate and B12, but not methylmalonic acid. Methylmalonic acid and homocysteine, they both are increased in B12, but only the homocysteine is elevated in folate. And other way to remember this is just look at the vitamin B12. 2 is there, that means two things are increased, that is homocysteine and methylmalonic. I am not going in detail of it, that what are the basic principles, what is the biochemistry. I am not going in detail of it. I am just giving you the hints that how to remember. Now autoimmune hemolytic anemia, on the periphery there will be the schistocytes, low hepatoglobin. Now why low hepatoglobin? Hepatoglobin is actually the protein that is formed by the liver. Whenever there is a destruction of RBCs in the blood, the bilirubin is released. Bilirubin itself is toxic. Therefore, the nature is increasing the protection of hepatoglobin in order to handle the bilirubin. But it is formed, as it is formed, it is consumed. Therefore, there is a low hepatoglobin level, elevated LDH, Coombs test could be positive, and raised unconjugated bilirubin. Now, the anemia of the renal disease. In the anemia of renal disease, patient would be typically having the features. If the cause is amyloidosis, there will be the history of diarrhea and the edema. On the urine there was the proteinuria. So any RA patient, any rheumatoid arthritis patient who is having the persistent complaint of diarrhea with swelling, just think of the amyloidosis, and amyloidosis itself may cause the renal failure, and renal failure itself may cause the anemia. So these are the causes of anemia in the rheumatoid arthritis. The scenario is usually given, just you should know that how to differentiate between the anemia of chronic disease and the iron deficiency anemia, how to differentiate between the B12 and the folate deficiency, and how to think of the autoimmune hemolytic anemia and the pernicious anemia in which the anti-intrinsic factor antibodies are assessed. In this way, you are asked to determine the cause of anemia and rheumatoid arthritis and treat accordingly. Thank you.